We're going to see the management of patients with non-ST segment elevation myocardial infarction or unstable angina. Here we have the cross-section of a artery. Here we have the atheroma plaque. There's rupture, so there's thrombus formation that obstructs partially the cross-section. So it is a thrombus on formation, it is not complete. If we have necrosis, so death of myocytes, it is a non-STEMI. If there is no yet necrosis, there is unstable angina. And in the non-STEMI, we will have elevated enzymes, cardiac enzymes, and in the unstable angina, we will have normal cardiac enzymes. Now the diagnosis is made with the EKG that will show ST segment depression or T wave inversion or both in at least 2 contiguous derivations. And the enzyme, we will take them at the moment of the pain, but maybe they will be normal. Some hours later we will take them again and we will see the curve. If we see elevation of the enzymes, even though at the beginning they were normal, it is a non-STEMI. If there was no elevation of the cardiac enzymes, it was a unstable angina. But the issue is that it doesn't matter if the enzymes were normal at the beginning, we need to do the curve to see if we have a non-STEMI. Now the management would be aspirin and clopidogrel, for example, some ADP receptor inhibitor in the platelet, and angioplasty or PCI between 72 hours, but remember that seconds are myocytes, so we need to do it immediately as we can, less than in 24 hours, less than an hour, etc. And also very important, heparin. So aspirin, clopidogrel, and heparin, because this is a thrombus formation and we want to prevent the obstruction, the total obstruction of the artery. So we need to stop the formation of the thrombus with heparin. And yeah, other things could be like beta blockers if the patient is not unstable, ACE inhibitors, both these are just between the 24 hours and for discharge. For discharge, we will also give statins at high doses and nitrates for pain. In the acute event, we can also give nitrates and IV morphine and metoclopramide. After the angioplasty, we will give afxizimab, that is a glycoprotein 2B3A inhibitor, and well, we can give this or some others like ticlopidine, but ticlopidine has increased risk of neutropenia, so usually we would give afxizimab. So the management for patients with acute coronary syndrome, for patients with STEMI, we usually give aspirin, clopidogrel. We prefer PCI, but if we cannot do it between 2 hours, we will give the thrombolytic. In patients with unstable angina or non-STEMI, it's aspirin, clopidogrel, heparin, and angioplasty. So the thrombolytic is for STEMI, the heparin is for the non-STEMI. Yes, even though after angioplasty in the STEMI, sometimes we use heparin. If the patient in the non-STEMI did not undergo the angioplasty for some reason, we will continue heparin for 48 to 72 hours. And at the discharge for non-STEMI and STEMI is quite the same: aspirin, clopidogrel, ACE inhibitors, beta blockers, statins at high doses, and the nitrates for the pain. So the drugs, aspirin and clopidogrel or prasugrel, ticagrelor, these are used for both in the acute coronary syndrome and thrombolytics for non-STEMI, heparin for thrombolytic for STEMI and heparin for non-STEMI, and the discharge could be exactly the same. Afxizimab, that is the glycoprotein 2B3A inhibitors, are used after angioplasty, most commonly on the non-STEMI patients, because in patients with STEMI, just with the angioplasty is alright. And if the patient had the thrombolytics, it would be contraindicated to give the glycoprotein to B3 inhibitors.